Dr.
Thank
Omar.
Thank you very much for your elegant presentation. Thank you, AASD, Dr. Ines, Dr. Amr, and Novo Nordisk for inviting me as a speaker to this session. I am going to speak about the gate to the future, the use of GLP-1 receptor agonists. Okay, this is my agenda. I'll take item by item. The first item is what are the statistics which were recently introduced type 2 diabetes prevalence. First of all, the incidence of diabetes worldwide is increasing. It will be 51% increase from 2019 to 2045. We will reach 700 million worldwide. In Africa, the number will increase from 19 million, it will be 47 million, which is a 143% increase. What about the Middle East, our country, and North Africa? It will increase from 55 million to 108 million by 2045, which means almost 96 to 100% increase. If you look at the number of cases, since 2000, we had 151 million. By 2019, we were worldwide diabetics, 463 million. It is expected that it will reach 700 million by 2045, and by 2030, it will be 578 million. We will reach the 700 million by 2045. If you look at our country, our beloved Egypt, we will find that the number of diabetics in our country will raise from 8.9 from last year million to 11.9 million at 2030 to 16.9 million at 2045, which means that we are gradually progressing. So, why do we treat diabetes? As you all know, at the time of diagnosis, we already have microvascular complications and macrovascular. We already have these complications at the time. But what happens? If we leave the blood sugar high, we will get a more increase in diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy. So blindness will increase a third, 10 to 40% neuropathies will increase. And as you all know that the nephropathy is a leading cause of chronic kidney disease. And also the macrovascular complications, which we are all afraid of, will happen. And this is heart failure, angina, a coronary artery disease, myocardial infarction, stroke, and this is a terrible end to the diabetic patients. So we need a multifactorial approach so that we can improve the management of type 2 diabetes and its complications. My target is to get the A1C around 7. Physical activity 150 minutes per week. Blood pressure will be controlled. Triglycerides and lipids to the limit, which is less than 150 triglycerides, and 50 or more, not less, LDL cholesterol. So the multifactorial approach is, I must control the glycemic control, I must control the lifestyle, I must control the blood pressure with various drugs, the dyslipidemia, and the platelet should be inhibited with aspirins or other products. What about the GLP landscape or scope? Well, the pathogenesis of diabetes includes impaired insulin secretion, increased hepatic production, impaired appetite regulation, decreased glucose uptake, increased glucagon secretion, decreased incretin effect, and increased glucose reabsorption. If you can see, GLP works on most of them. It works on the impaired glucose secretion or insulin secretion. It causes insulin to be secreted. On the hepatic glucose output, it decreases it. On the glucagon level, it will decrease it. Also, it will increase the incretin levels, so it is multifactorial and will be of great value. What about beyond the glycemic control? Yes, the beta cell function will improve. the beta cell death or apoptosis will decrease, insulin formation will increase, cardiovascular risk, we have multiple studies that it decreases the cardiovascular risk, the fatty acid metabolism, and improves the cardiac function. It will decrease the systolic blood pressure, the inflammation, as well as the body weight and the satiety. It will decrease the body weight and the food intake, and it will increase the satiety, as well as many other things. If you look at the recent consensus or guidelines or consensus that will be changed to guidelines in the future, we find that GLP-1 is in every aspect of it. If there is cardiovascular risk, if there is chronic kidney disease, if there is hypoglycemia and I am afraid of it, if I'm using the drugs that work on the kidney, even in the TZDs it can be used, as well as if I want to control the weight gain, or I want to promote weight loss, in all of them it can be added. It should be noted that cardiovascular risk only occurs in less than 30 to 35% of the patients. So the majority, which is 60 to 65%, do not have the cardiovascular risk or the chronic kidney disease. Okay, most of the guidelines in the past 2 years did the following. They put lifestyle in the first class, and then they said that if you need an injectable therapy to reduce the A1C, please consider GLP-1 prior to insulin. And if I am still above the targets, that is to say I am 1.5 degree above the normal, which I am targeting, which is above the 7, then please add basal insulin. Please start, initiate, and then titrate. Do not leave the patient for a long period of time on 1 or 2 drugs until the A1C is very bad. Okay, what about the product that was introduced in the market is semaglutide. It is a breakthrough. It is human. We have human and we have exenidide based, which is the Gila monster, the lizard. Okay, the exenidide based had a problem. It is quite different from the human. It causes nausea and GIT disturbances and multiple side effects. But the human, the side effects are less. We all know we have the weekly by one of the companies, and we have the once daily liraglutide Victoza by Novo. This new product will be introduced. There is oral every day, and there is subcutaneous injection every week. And this will be a breakthrough when it starts. Okay, what did they change? They changed 3 things from the human GLP molecule. At position 8, they added an amino acid. At position 34, they added an arginine instead of lysine, and they put a spacer. What do you mean by a spacer? Fat and amino acids, which are put on it so that it will prolong the duration of action. When they did this, what happened? The first phase and the second phase, insulin secretion increased. Look at the first curve up and look at the curve below it. Second curve, diabetic blunted curve. First, when I use the drug, yes, marked improvement happens. So the mechanism of action of semaglutide will be the following. It will increase insulin secretion. It will decrease the hepatic glucose output, reduce the energy, food consumption, satiety, and it will reduce the body weight, increase the satiety and reduce the body weight, and it will have other effects on atherosclerosis. What about the trials that were introduced? Well, there are more than 11 trials which are all called SUSTAIN. I will not enter into the details. They will be discussed thoroughly. But I must remember that the first one, which was SUSTAIN 1, in order to enter the trials, they were done on comparison to placebo. The second 5, from 1 to 5, all of them on oral. Number 6, cardiovascular, and the rest until 11, all of them on injectable therapies and insulins. Now, if I look on the dark blue, look at it, all of it marvelous results. If I compare semaglutide alone with placebo, better effect. If I compare semaglutide alone with the oral sitagliptin, metformin, and TZDs with the other one mono alone, far more better results in the second study. If I do it all of the studies, I will find that it gave a better result single-handedly. The others all had metformin and other drugs. And if I compare them to all the injectable GLP-1s which are present in our market, a far more better result of them was obtained. If I look at the following: semaglutide alone in comparison with exenatide plus 2 oral drugs, semaglutide was more superior. Dulaglutide and metformin, it was also semaglutide was more superior, and better results as regards A1C were found in all of them. And with the liraglutide as well as insulins, it gave better results. Okay. The same thing, if I look at the body weight and the changes that happened, best results from all drugs were, even they were better in weight reduction than the exenatides with oral hypoglycemics, dulaglutide with metformin, and liraglutide. So far more better results were given. Again, it achieved a better hemoglobin A1C control, less than 7 or between 6.5 and 7. The one in dark blue was far more superior than all other combinations. Again, if I look at the weight loss in all the studies that were done, all of them, it gave a better result, the ones in blue, dark blue. So from these studies, it is quite obvious that this drug will be superior. It depends on us trying it later. It will be put in 3 combinations in a modern pen. When the pen is introduced, there will be a green, a blue, and the third one, the 0.25 pen, will also be present. And they are very similar to the new pens that are used now. If you have NovoRapid, the new pens, these are very similar to them. Summary and conclusion. Semaglutide provides consistent glycemic improvement across all the studies that were introduced, the sustained studies from 1 to 10. As I said before, the first 5 were with oral, and the second 5 were with injectable therapies and insulin. It resulted in significant weight loss across the whole scope of the studies, significant reduction of the major adverse reactions, and a 26% reduction versus placebo was seen. If I compare it to the injectables, it is far more superior, GLP-1, than the other ones. Also, it is well tolerated with a safety profile typical of GLP-1 receptor agonists. I hope that I was concise. I was asked only for 18 minutes. I think I finished it in less than 15. And thank you very much, all of you.